Hi, everyone. We're excited today to talk about our work published in this issue of Gastrointestinal Endoscopy titled Impact of a Simulation-Based Ergonomic Training Curriculum on Work-Related Musculoskeletal Injury Risk in Colonoscopy. My name is Rishad Khan, and I am an internal medicine resident at the University of Toronto.
I'm Samir Grover, a gastroenterologist at St. Michael's Hospital in Toronto and an associate professor in the Department of Medicine at the University of Toronto. We first became interested in this area because, like most gastroenterologists, we noticed that our colleagues frequently had MSK strain injuries. When we looked at the literature around this, we saw that these injuries seemed to be the rule and not the exception.
Now, there are surveys as far back as the 1980s, but the most recent large survey in 2015 showed that more than 53% of the surveyed endoscopists had at least one endoscopy-related strain injury. And maybe more concerningly, a 2019 survey of GI fellows showed that almost half of them had a strain injury within their first 12 months of performing endoscopy. And while these risks are well known, training novices in proper ergonomic behavior is certainly not the norm in endoscopic training programs.
In this study, we designed a curriculum grounded in education theory to mitigate the risk of work-related MSK injuries amongst novice endoscopists done at the University of Toronto. And we delivered and built this curriculum into our existing simulation-based training infrastructure through which all novice GI and general surgery trainees rotate prior to their first patient-based endoscopy. Our intervention had 4 parts. The first was a 1-hour lecture based on the ergonomics literature on a number of topics, including optimum stretcher, patient, and monitor positioning, recognizing strain, and taking breaks when needed, correcting situations which can cause unnecessary strain, such as removal of loops from the endoscope during colonoscopy, and communicating with the team in order to perform the procedure ergonomically. The second part of the intervention was a short narrated video where an expert performed an endoscopic procedure with ideal ergonomics. This was done to demonstrate benchmark performance. The third part was during simulation-based training, where attending endoscopists performed ergonomic-specific feedback to participants using a checklist that was provided. And finally, the participants themselves completed the endoscopic ergonomics checklist to facilitate self-reflection on their ergonomic behavior during endoscopy.
We compared this group of novices who went through our standard simulation course 1 year prior, where there was actually no ergonomic specific training. And in our primary outcome, we looked at participants' ergonomics during real colonoscopies on live patients 4 to 6 weeks after the course. 2 expert blinded assessors evaluated the ergonomics of the trainees using 2 tools which have been validated in a range of workplace settings. One called the Rapid Entire Body Assessment, or the REBA, and one called the Rapid Upper Limb Assessment, or the RULA.
We found that at 4 to 6 weeks, the ergonomics group had a significantly lower risk of MSK strain injury based on the REBA scores compared to the control group. The ergonomics group received median REBA scores of 6, corresponding to medium risk of MSK injury, while the control group had medium REBA scores of 10 and 11 in the 2 procedures we assessed, both corresponding with high risk.
Now, interestingly, both groups at the baseline assessment, so prior to going through the course, were in the medium risk REBA range. Over the course of the training, though, the control group actually got worse, while the ergonomics group stayed in the same MSK risk category. To us, this suggests that poor ergonomic form is learned and not innate, especially during the initial stages of endoscopic training.
And this is not surprising. In a recent commentary by Xiao and colleagues, the authors postulated that prioritization of technical skills during initial endoscopic training may come at the cost of ergonomics. In light of these recognized risks to endoscopists, the ASGE and other GI societies have called for an increased focus on ergonomics, particularly in training. Simple measures such as using a checklist to provide ergonomic-specific feedback or showing trainees benchmark videos may help. And these should all be built into larger efforts to restructure endoscopy suites to maximize ergonomics for the participants involved.
And we also have to consider some of the limitations that we face. Now, even with training, novices in our study remained in the medium risk group. And we also don't know long-term what the effect of these interventions on real MSK prevalence is. We do need longer-term studies looking at how different interventions, whether it's changing the setup of an endoscopy suite or delivering educational interventions such as ours, can impact endoscopists' risk of strain injury. Figuring out what works, how to implement it, may result in fewer musculoskeletal strain injuries among endoscopists, and also reduce the chance that their procedural performance is limited by injury.
We would like to thank Gastrointestinal Endoscopy for providing the opportunity to publish and speak about this work, and the reviewers and the editor, Dr. Shergill, for the thoughtful comments during the review process. Thanks very much.
Thank you.